and I wasn't sure what is actually relevant for people. So that's why I asked for them to give their input. So I thought I'll just make it very brief. It's going to be quite relatively brief, but hopefully quite practical. The things that I felt that might be useful, especially for those who are in their foundation year training, because that's the 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 biggest group from the who is the target audience of this of our sessions, and obviously I hope it will be useful. Okay, so the title I give for this is just a play on words. The good roommate. Um, it's essentially, let me just click this. Yeah, like how to be good mate to the rheumatology doctors, meaning that how not to annoy a rheumatologist, because obviously, as Dr. Hafiz has mentioned, you don't really see rheumatology patients on the ward, but you do get them every now and then. And as I said, I hope this will be quite useful for those who are based on the ward or in a GP setting. And I would like to encourage you to type your answers in the chat box. I was hoping to use a poll function on Zoom, but then I wasn't able to access it. But that's something that can be considered later in the future. Okay, so the learning objectives for today is quite brief. So first one is acute hot joint, and the next one is giant cell arthritis. And we'll leave it for some questions and answers at the end. Okay, acute hot joint. So acute hot joint. What does this mean? If you could just type your thoughts in the chat box, and then, or alternatively, you can also just unmute yourself if you would like to. But if not, just type in the chat box. Just based on this phrase, acute hot joint, what's the first thing that comes to your mind? Okay, thank you. Thank you, Sir, for kicking things off. So septic arthritis, and then there's also tender erythematous swollen joint. Okay, referring to that photo, great. And then sudden onset pain, red, painful joint. Yeah. So yeah, I agree with you. So those are the common things that you think about whenever we talk about acute hot joint. So let's go through some cases. So first one is a 50-year-old gentleman with acute onset pain and swelling in the left knee. But then if you look at the photo, it's actually the right knee. Apologies, I couldn't find an accurate photo at the time. And he has type 2 diabetes. He also has rheumatoid arthritis, and he's on methotrexate. MTX is the acronym that we use. He also has fever, and he is generally unwell. Moving on to the next slide. Okay, so what would you do? Type in the chat box, just based on this. Let me bring up the chat function again. So what would you do in this case? Or what are your thoughts? How will you assess this patient? Yeah, you can inquire deeper into the history. Okay, so let's say, so he has fever, generally unwell. The pain started like maybe around 2 days ago and gotten very worse in the last few hours. It's red, it's hot, it's swollen. And Mustard already said, consider aspiration. Great, yes, good answer, consider aspiration. And if I were to just say, what's the most likely diagnosis based on this? What would you say? What's the most likely diagnosis from this presentation? Yeah, I agree. It's most likely to be septic arthritis. So yeah, and then just wanted to say that whenever you think about septic arthritis, it's easy to think about, yeah, aspirate the joint. And you would, yeah, true as well. It can also be a rheumatoid arthritis flare-up, which is why aspiration is key. So that's a good differential diagnosis. So so the first thing is, as I said, aspirate the joint, because we want to see the white cell count number, as well as if you think it's septic, Don't just think about the knee, think about the whole system. So you want to do blood cultures, urine culture. You also want to do chest x-ray, throughout infection, obviously bloods in addition to that. And ideally you want to do all of these cultures, blood culture, synovial fluid aspiration, and the urine culture before the antibiotics if possible. And then who do you refer to afterwards? Don't refer to rheumatology, you refer to orthopedics. So I work in Salford Royal, and this is probably the very last hospital whereby rheumatology registrars had to review septic arthritis. And thankfully, we managed to push this to the orthopedics team, because I mean, to be fair, there's only like 2 registrars in rheumatology in Salford Royal, whereas there's like 10 or something orthopedic registrars there. So my point is 99.999% of the time, it'll be orthopedics that takes over septic arthritis. So whenever you see septic arthritis in A&E or in a GP setting, refer it to orthopedics. Don't send it to rheum. And especially if you're coming to Salford Royal at any point, it's no longer rheumatology. It is now under orthopedics, just to be clear. Okay, so let's go through the things that we discussed. So yeah, treat septic arthritis. Obviously, you start, do your A to E assessment, the cultures as we discussed, bloods, and last but not least, refer to TNO, because orthopedics, we need to do wash out of the joint, because that's the treatment for septic arthritis. And then they'll take culture from the biopsy sample of the synovium from the patient's knee or wherever joint that is involved. Great. If you have any questions, just ask throughout the presentation. I'm more than happy to answer as I go. So next one is same photo but different case. Again, it's not the left knee on the photo. So it's a subacute hot joint. It's a 50-year-old gentleman with pain and swelling in the left knee. Started 3 months ago. He's known to have type 2 diabetes and osteoarthritis. New score of 1. Not everything else is fine. So based on that history, what would you do and how will you approach the situation? What are your thoughts? What's your differential diagnosis? Inflammatory OA, good differential, yes. Gout, yes. Potentially. Anyone else? Pseudogout, okay. Can I ask Farah why you might think it's pseudogout? You can just type in the chat box if you're happy to do that, or you can unmute yourself, whichever you prefer. Is there any reason why you chose pseudogout? Just curious, that's all. Okay, yeah, I mean, the knee can, yeah, pseudogout can actually happen in any joints really, but the reason, so essentially pseudogout can happen in areas where there is osteoarthritis. So pseudogout, yes, it can happen in the knee because knee OA is quite common, and the other place is around the wrist as well. So yeah, if you have OA in that area, it's possible that you're going to get crystal arthritis as well. So yeah, that's a good differential. Fine. So if there are no further answers, just go back to that history. Okay, so what I wanted to say was, how do I go back to the previous screen? Okay, this is a subacute history, so it's 3 months ago. Okay, so meaning that when I say 3 months ago, it doesn't mean that it's not that severe. So what I wanted to say was it started 3 months ago. It's persistent. The pain is probably 5 out of 10. So he's coping with it. He goes to work. He can get flare up every now and then. Just bearing in mind, no formal diagnosis of any rheumatologic conditions at the moment. And then, so what else do you want to ask from the history? You want to type your thoughts in the chat box again, or unmute yourself. if you're happy to do that. So based on the history, what else would you like to know? Any history of trauma? Yep, good. Obviously, if you have any trauma, then you think about fractures, then you want to do an X-ray. Anything else they would like to know? Or ask? Yep, good. And the other joint involvement. So is this the only joint or were there others? So let's say he has other joints. So he has it in the small joints of the hands, both hands, with the knee. What else would you like to know? Rashes? Okay, yeah, you can consider CTD features. CTD meaning connective tissue diseases. And this will be a whole new session actually, CD, but I'm not covering it in my session today. But yeah, rashes are fine. Let's focus on the joint pain. How do you differentiate whether this is a rheumatology kind of joint pain or not? Just hinting on that. Is there anything specific? Yeah, on movement or at rest. So what's the key thing? What's the key word that we're trying to differentiate with regards to the joint pain? Yes, inflammatory. Thank you. Thank you, Musa. Yeah, inflammatory. It's about inflammatory joint pain or not. So let's just go through next slide. Yeah, so inflammatory joint pain. So you want to know whether this is inflammatory or non-inflammatory. That's basically what I do on a daily basis in my clinic. Well, whenever they come for inflammatory arthritis, obviously. So as we know, inflammatory joint pain, it gets worse with rest. It gets worse early in the morning, and patients can wake up at night with the pain. Early morning stiffness, yeah, it can be more than 30 minutes, more than an hour, and the joint swelling is persistent. So does anyone know why the pain is worse with rest, or why it is worse early in the morning, and why it can get worse at night? Is there any way, like, what's the logic behind it? No? So essentially, if someone has inflammatory joint pain, let's say they have it in their wrist, and then they rest it. Let's say they have inflammatory arthritis, okay, in the wrist, and then they rest it, they don't move it. And then the inflammatory cells will obviously be in there and they stay in there. Yeah, so they get stiffness, which is worse after rest, because they do have the inflammation in the joint involved. And if they don't do anything, it stays in there and then it gets swollen and you get synovitis. That's why the pain is worse with rest. Whereas if they keep moving, it's more likely that if they keep being active, the pain improves because the joints are not static, essentially. So that's why it's worse with rest. And then it's worse at night because when you go to sleep, you just lie, let's say, on your right hand side or on your back, and then the joints are static. That's why the pain gets worse at night. The inflammation stays in the joints. And then it also gets worse in the morning because that's the longest period that they've sort of like being inactive in terms of joint movement. So that's why they get early morning stiffness. So this all makes sense. So this is a way for you to remember like why inflammatory joint pain behaves in this way. And then they get this persistent joint swelling. It's all have to do with the inflammation in the joints involved. And moving on to the next slide. Okay, so some of the investigations that you would do. Okay, bloods, routine bloods, so FVC, UNE, LFTs, and then you can do CRP and or ESR, immunology. Bearing in mind this is an inflammatory case of that guy. Okay, this guy, the guy with the right knee pain, but the history says left knee pain. So you do immunology, including rheumatoid factor and anti-CCP. If you're considering CTD, CTD is connective tissue diseases, yes, you can do ANA. Again, I'm not covering CTD in full detail for this session because it's quite, again, a whole new session. X-ray, we discussed about potential history of trauma earlier, and aspiration is key. So whenever someone comes to my clinic with swollen knee, I always get a syringe and needle and aspirate it because that will tell us whether it's inflammatory or not. Right, now we've talked a bit about inflammatory arthritis, and one of the things that I like about rheumatology is it's more or less like a pattern recognition kind of specialty. I mean, even for vasculitis and connective tissue diseases, they're quite complex and quite weird and wonderful. But let's just focus on inflammatory arthritis because that's what we're talking about at the moment. So that guy, okay, just imagine if this patient has multiple joints affected, and it is presented by this diagrams. So in number one, looking at that photo, what do you think this patient has? Yes, RA. Rheumatoid arthritis because it's symmetrical, it's polyarthropathy, poly meaning more than 4, and those are the joints that usually involved. In RA, they tend to happen and affect the MCPJ. Not sure if you can see my mouse, but it's the MCPJ. MCPJ is the metacarpophalangeal joint, which is the easiest way to say is the knuckles of your hands. And then, yeah, as I said, it's symmetrical. So if you look at the photo, it's more or less symmetrical. It can also affect the MTPJ of the feet. And then what about number 2? What could this patient have by looking at the photo? Thinking about inflammatory arthritis again. Yeah, so yeah, psoriatic arthritis. I think that's what you were alluding to, psoriatic arthritis. So psoriatic arthritis tend to be asymmetrical, right? If you look at the photo, it is asymmetrical. It can be, yeah, polyarthropathy or oligo, and they tend to have a history of seronegative spondyloarthropathy. So seronegative spondyloarthropathy is an umbrella term for a number of inflammatory arthritis, which include psoriatic arthritis. And again, in the photo as well, if you look at the right hand, you can see the index finger is, there are 3 joints that were sort of like affected and swollen. Do you know what that is representing? Or what does that represent? Very common in psoriatic arthritis. Sausage, yes. What's the medical term, Naeem? Selain pada sausage. Yes, dactylitis. Yeah, sausage fingers, sausage toes. Orang ada sausage toes juga. If you look at this photo, left foot, left second toe, they have dactylitis there as well. So they have dactylitis, or sausage fingers or sausage toes, and then they can have SIJ involvement. If you look at the photo around the pelvis, there's SIJ involvement on the right side, and it's asymmetrical, and they can have, not necessarily, but they can have skin psoriasis. So you can have psoriatic arthritis without psoriasis. It's possible. And it's possible to have psoriatic arthritis before having skin psoriasis. And other things that you might want to ask would be uveitis or iritis. You might also want to ask about inflammatory bowel conditions. So Dr. Hafiz would be an expert in that. So things like Crohn's and ulcerative colitis. And they are associated with HLA-B27 positivity, especially among Caucasians. And number 3, what could this patient have from that photo? So this is another type of seronegative spondyloarthropathy. Yes, very good. What's up? AS, ankylosing spondylitis, because of the involvement of the spine and the SIJ. And you can also get peripheral joint swelling. Not necessarily in the photo, it shows the knee, the shoulder, the hip, but again, it can affect really any joints as well. And number 4, the clue is not inflammation. It's not inflammatory arthritis, usually, but it can be. What could that be, number 4? Reactive, okay. I mean, reactive tends to be like monoarthritis or oligo. Think non-inflammatory. The most common non-inflammatory arthritis, yes, osteoarthritis. It is actually osteoarthritis. So if you look at the photo, osteoarthritis can affect weight-bearing joints. So the knees, the hip, the lumbar spine very commonly affected. And then first CMCJ meaning first CMCJ of the thumb. So if you look at the base of the thumb in the photo, both were affected. And then first MTPJ as well, if you look at the big toe. One more thing I forgot to mention, sorry, psoriatic arthritis tends to affect DIPJ, okay? And same with OA, DIPJ tends to happen. And if they get bony swelling, so they don't tend to get synovitis, but if they get synovitis, we can call them inflammatory osteoarthritis. But again, it all depends on the clinical assessment of the clinician. But assuming they don't have inflammatory osteoarthritis, but they do have bony swelling, bony meaning hard swollen joint of the DIPJ. So look at the photo, there's a DIPJ involvement and the PIPJ. There's a specific name for them. Do you know the name of this bony swelling? Let's say for the DIPJ, what's the name of it? DIPJ meaning this one. I forgot I have my camera on. So this is a DIPJ, PIPJ. Yes, very good. Haberdens notes, and this one, if it's Bouchard's, yeah. So do I remember it as happy birthday? Someone mentioned to me it could also be HP pencil. But yeah, so Haberdens and Bouchard's. Yeah, boleh juga macam tu, hadapan belakang. Yeah, so if you see Haberdens and Bouchard's, so you can say this guy have OA. Because sometimes people say they have swollen joints. I mean, it is swollen, but it's bony. It's not synovitis. The only way to tell whether it's synovitis or not, you just have to, palpate, examine, and then with experience, you can tell whether it's synovitis or not. Even for me, I just have to start doing it when I was an ST3 and just build up my experience. And obviously, same as GPs. GPs just, keep on examining and they just become more competent as they see more synovitis in their surgery. Fine. So I think that's it for this pattern recognition process. Just want to have a look at one of the questions from Dr. Naeem. So if you suspect inflammatory arthropathies, what basic tests would you expect your medical colleagues have done before referring to him? So if you see someone with synovitis in clinic, and the basic tests that you can do would be inflammatory markers, so CRP and or ESR. You can do rheumatoid factor and CCP, because if it's negative, then it's seronegative. If it's positive, not necessarily they have rheumatoid arthritis, but then then we know that if it's positive, they have an increased risk of rheumatoid arthritis, but only in the context of if they have the synovitis. So if they have synovitis, history suggestive for inflammatory arthritis, then you can do this RF, CCP, CRP, ESR. Those are just the basic ones. So any clinician can, we would encourage that you do that as a minimum. And as I said, if you consider CTD, so connective tissue diseases, so if they have anything like just briefly here, photosensitive rashes, if they have swallowing difficulties, or if they have dry eyes, dry mouth, miscarriages, etc., etc., all the other CTD features that you might come across, then you can do A&A as a screening tool. Again, this is just as a screening for the inflammatory arthritis. And then when the patient comes to see rheumatology, we will thank you for doing the basic tests because we at least have some initial investigations. So I would say those are the minimum, at least. Because you don't want to refer to rheum without doing CRP and ESR. I've received that before, and they were not good roommates, I can tell you. Okay, now, just go back to my slides. Okay, so bonus question. So if a patient has history of inflammatory polyarthropathy, but joint swelling is not persistent, what could this patient have? So, okay, firstly, let's just make it simple. If they have, so the question is, let's say this patient has history of inflammatory polyarthropathy and persistent joint swelling. So what's the diagnosis? What's the diagnosis if they have inflammatory polyarthropathy with persistent swelling? So basically the answer is inflammatory arthritis. So it could be rheumatoid arthritis, could be psoriatic arthritis, could be do you want to answer just now, Malin? Or okay. Or it could be, you know, ankylosing spondylitis with peripheral joint synovitis as well. But it's okay. So if they have persistent swelling, that means inflammatory arthritis. Like when I discuss rheumatoid arthritis, psoriatic arthritis, or any other. But if they have the history, but the joint swelling is not persistent, what could they have? So let's say when you see them, yeah, they say, okay, inflammatory history, inflammatory joint pain, was at rest, early morning stiffness, 5 hours, joint swelling can persist for like 3 days, and this happens every 6 months or so. So what's this diagnosis? I would say it's less common than RA, but you can see it in some patients. Does anyone know? What could this be? No? Okay. I'm going to tell you the answer now in a few seconds. Yeah, I mean, could be gout. Could be gout, but I'm trying to allude to something more less common. So someone just send me a direct message saying that they know the answer. Not sure why they don't want to answer it. Sharing is caring, by the way. Dr. Naeem says reactive arthritis, migratory arthritis. Yeah, I mean, yeah, okay. So yeah, the description is migratory arthritis, but what's the name of it? It's not reactive arthritis, by the way. As reactive arthritis happens usually secondary to something, usually to things like sexually transmitted infection or UTI or gastroenteritis. Yeah, I mean, yeah, perineoplasty is possible. But I wanted to go to tell you more is this palindromic rheumatism. Oops, sorry. Okay, so palindromic rheumatism, it's the way well, it's basically like what this description is. So they can get synovitis. So it is inflammatory, but then the joint swelling happens intermittently. That doesn't mean that they don't have it. They have it. It's just that they come and go. So think of it like intermittent RA. And they don't usually need much treatment really. But if they come to rheumatology and if this is becoming more frequent, you tend to start them on a milder DMARD. DMARD meaning disease modifying anti-rheumatic drugs. I'll just type it in the chat box so that you can see how it's spelled. In case you're not familiar with the term. So, and what we normally give is hydroxychloroquine for this patient, usually. In some subgroups of patients of palindromic rheumatism, it might be the earlier phase of RA, meaning that they might have palindromic rheumatism for, let's say, 5 years, 10 years, and then eventually they develop RA, meaning that it's more persistent, and then they might require stronger DMARDs. So something stronger than hydroxychloroquine. Okay, great. Now, case number 3, acute hot joint. Okay, so now we have a different guy. He's a fisherman, 50-year-old gentleman with pain and swelling in left first MTPJ, which started 2 days ago. So obviously, I think a lot of people have answered this already. I'll just go straight to it. What do you think this is? Okay, who wants to say what it is? Anyone? It's the most popular answer tonight, I think. Okay, no? Okay, gout. Yes, gout. It's gout. So acute episodes, yeah, they can have acute episodes of joint swelling, typically affecting first MTPJ. If you remember that photo that I showed you just now about the diagrams, number 4, about osteoarthritis, though the first MTPJ was highlighted because you can get OA in first MTPJ. And crystal arthritis, crystal meaning gout, because they have uric acid crystals, or pseudogout, where they have the CPPD crystal, they can affect those areas as well. But gout is more common in first MTPJ. Risk factors for it would be, yes, men, postmenopausal women, because estrogen and progesterone are protective, high BMI, alcohol, diet high in purine, so things like shellfish, red meat. So this guy is a fisherman, so he might eat a lot of seafood, and of course diuretics. Question number 1, a new patient diagnosed with gout, what is your initial treatment? I'm going to type some answers here because I don't have a poll. And you can just say, just let me type first. I hope this works. What would you choose out of these options? So I put down naproxen, colchicine, steroids, tramadol. How would you treat gout? So you can just type the numbers in. Okay, thank you, Eamon, for choosing 2. Anyone else? Okay, everyone loves colchicine. So yeah, so the answer is all of the above except for number 4. Okay, so all of that is the right answer, so, except for tramadol. So you can give NSAIDs, so ibuprofen, naproxen, can give colchicine, and of course, if they have any contraindications to the NSAIDs or the colchicines, you can give steroids, but don't give tramadol or codeine to them. I mean, you can if there are no other options, but the first line would be NSAIDs or colchicine or steroids. Yeah, so this is a treatment, initial treatment, okay? Okay, a new patient known to have gout. When do you consider ULT? ULT meaning urate lowering therapy. What am I trying to say here? Okay, I think I mean what are the criteria for that? Let me just, should I tap again? Okay, no, that's okay. Just tell me, when do you consider urate lowering therapy? Or rather, yeah, that's fine. Just tell me, when do you think we should start urate lowering therapy such as allopurinol? So let's say they have gout, you just start it, or do you leave it for now until they have tophi? Tophi meaning uric acid deposits in the skin. Yes, that's a very good point. Thank you, Amalin. After acute attacks settle. For some reason, historically, people tend to wait until like 6 weeks or so before they can actually start any ULT. But nowadays, we would say it's just like after a week or 2 weeks, that's sufficient for them to get on allopurinol. So this is the criteria when you need to consider urate lowering therapy. So if they have 2 attacks or more in a year, if they have tophi, chronic gout, if they have joint damage, because they can get erosions in the joints, or if they have renal impairment, they have CKD, and other things. There are more than this actually, but this is just a few things. Okay, obviously diuretic therapy, because it's also a risk factor. Okay, so a patient known to have gout develop an acute gout episode. Patient is already on allopurinol 300 milligram OD. What would you do? Okay, now I'm just going to type some answers here. Then I would like you to choose if that's okay. So let me just write them down. Regarding ULT, do you titrate the allopurinol dose initially to a certain level? Yes, that's right. So let's say this fisherman comes to us, okay, and apparently he has had gout multiple times in a year. And then so initially you give either NSAIDs or colchicine or steroids. And then after, and we know that uric acid is raised. So they're by raised, meaning this is UK unit, okay? So more than 300, okay? So if they're more than 300, I mean, there's some leeway. So if they have other comorbidities, it might be hard to take. So 300 is the tighter, like a tighter target. But 360 is also another target that you could use, especially in those that might be difficult to achieve the target. So if they raised, so more than, let's say more than 360, then you start with allopurinol first. If they're quite elderly, I tend to start at 50 milligram once a day. But if they're youngish, young meaning like 50, 60, then I can start 100 milligram once a day. And then you repeat the uric acid after 4 to 6 weeks to see what it is. If it's now, let's say, below 360, I probably would say that's fine, and then just continue. But if it's still more than 360, I would titrate it further. So let's say 200. So 200 milligram once a day. And then repeat the process until the uric acid is lower than 360. I hope that makes sense, Naeem. Let me know if it doesn't make sense. And then just typing the answers. Is there anything else I would add? Okay, so this is the question. What would you choose out of the following choices? Okay, thank you, Michelle, for answering firstly. So at naproxen. Anyone else? Yeah. So the answers are the ones that you've typed. So 1 and 4 are the correct ones. So 1 and 4 are both correct. What you should not do is don't stop the allopurinol. Yeah, don't stop the urate lowering therapy, because that just makes things worse. So just continue. Don't change anything, because if you increase the allopurinol, you might make the gout worse because you're just increasing it further. But don't reduce it, because again, because they're already on they might just need to titrate it up a bit, but you don't want to titrate in the acute phase. So you continue with the allopurinol 300 milligram OD, and then you just do your initial treatment for gout, which would be NSAIDs or colchicine, or steroids, whichever that they can have. But yeah, usually give NSAIDs or colchicine, unless of course they have poor kidney function or if they're quite elderly, contraindications, then yes, you can go with steroids. And one thing that I wanted to mention was, if this is a new patient, not relating to this question, if this is a new patient with gout, first diagnosis of gout, and you want to give colchicine to them, when you want to start the allopurinol, it's important that you continue the colchicine, because if you stop the colchicine and continue with allopurinol or any other urate lowering therapy, the gout can get worse. So it's important to continue colchicine. So colchicine is usually 500 micrograms OD, BD, or TDS. Usually we give BD, and then we just monitor the use and ease, make sure that they don't have diarrhea as a side effect. And you can continue this for up to 6 months. If you look on the BNF, it will say, like, I can't remember, 3 days or 1 week or something like that. And pharmacist or any other, I mean, no rheumatologist will obviously query it, because that's not what stays in the BNF, but then we follow our guidance from the BSR. BSR is the society, British Society for Rheumatology, and you can give the prophylaxis for colchicine up to 6 months, which is actually, yeah, really helpful, because it will prevent the acute attacks of gout when the ULT is being started. So, yep, like we mentioned earlier, acute treatment includes NSAIDs, colchicine, steroids. Never stop the ULT, unless of course they have other reasons. And repeat uric acid level after acute phase. So this can be, oh, sorry, you shouldn't repeat it after 10 days. Sorry, this is wrong. What I'm saying is you can start the ULT after the acute phase. You can repeat the uric acid in 4 weeks. Don't repeat it too early, because it won't be that accurate. And then you titrate the ULT depending on the serum uric acid level. So this is the guidance, BSR guidance for the management of gout. So just Google it. It's free, everyone can see it. And then it has nice diagrams and stuff, and you can have a read about the recommendations. Very useful for everyone who wants to manage gout in the ward or in the community. I don't think we have time for GCA, but obviously this can be done in a different session. So I would just like to stop there, if that's okay, and then take some questions. And while I do that, I need to plug in my laptop, because it's going to go to sleep soon. So thank you everyone for listening, and I will now take any further questions.
Thank you very much, Adlan, for the presentation. I think many people can relate to this, because I'm pretty sure that everyone has seen an acute hot joint here clinical so far.
Sorry, Dr. Hafiz, I cannot hear you clearly. I'm not sure whether it's my battery.
No, I think it's just my microphone that is not working. Sorry. Yeah, I think now it's better. Thank you, Dr. Adlan Wafi, for the presentation on acute hot joint. I'm sure everyone can relate to this. I'm sure everyone has seen at least one case of acute hot joint in their clinical practice so far. So we have one question from Musab. Okay. Differentiating inflammatory OA, osteoarthritis, versus rheumatoid arthritis, and is it relevant in acute setting?
Okay, so inflammatory OA versus RA. So for inflammatory OA, so firstly they need to have OA, so meaning that they need to have osteoarthritis. You've done x-rays, you've seen the changes of OA. So the four common features of OA would be the subchondral sclerosis, narrow joint space, osteophyte formation, and I mentioned everything, subchondral sclerosis, subchondral cysts. Yeah, so all 4 of that. So if they have OA from previous, and then they come to you and they have synovitis, and you've investigated the patient for RA, so this would be obviously rheumatoid arthritis, CCP, and I would say, I mean, inflammatory OA is quite a uncommon kind of diagnosis. More often than not, let's say the RF and CCP is negative. If this is a patient that I've seen, I would actually, if they have inflammatory history, I will go with actually seronegative RA. if they are affecting the joints which I know about, which is MCPJ, typically symmetrical polyarthritis, like the pattern that we saw in the diagram. Let me bring up the diagram one of the four. Yeah, so if they behave in this way, they should still fulfill RA really, rather than inflammatory OA. So I think inflammatory OA is becoming more of a diagnosis that some of the clinicians who might know the patient really well, and they don't really have any suspicion that this patient has inflammatory arthritis, and it's just this OA that's been ongoing for a long time, and suddenly they develop synovitis. So I guess that's when they label this patient as inflammatory OA. And regarding your question, is it relevant in the acute setting? I don't think so. Not really. I mean, in the acute setting, the management would just be similar. In the acute setting, let's say they come to the ward or a GP setting. Obviously, if they have synovitis in the GP setting, you might want to refer to rheumatology and give them some pain relief. On the ward, if they have synovitis, you don't have to get rheumatology to see them at the time, because obviously we're not going to start them on any specific treatment. They can just give them pain relief. So pain relief, if it's inflammatory arthritis, you can give NSAIDs if there are no contraindications, plus minus PPI, paracetamol, codeine, tramadol, etc. For the time being. We don't tend to advise giving them steroids, because if you give patients with synovitis steroids, the synovitis will go away. And then when they come to rheumatology clinic, there won't be synovitis, so we can't really start them on treatment, because we need to see the synovitis and examine the synovitis before we can give them a diagnosis. So please don't give steroids unless you've run out of options, or you discuss it with the rheumatologist, or the patient is in such severe pain and steroids is the only thing you can think of. Okay. Thanks.
I have a question, Adlan. Sometimes we see rheumatologists give patients intra-articular injections of steroids in the cases of osteoarthritis or joint pain in general. Is there any caveat to that? When will you consider giving intra-articular injection of steroids?
Is this for inflammatory arthritis or for osteoarthritis? Or
for osteoarthritis?
For osteoarthritis, okay. So if it's osteoarthritis, I think it really depends on the rheumatologist in question. If it was me, I don't want them to be seen in my clinic in the future, because obviously it's osteoarthritis. We shouldn't really be following them for a long time, because they don't have, they don't have any autoimmune diseases. They just increase the patient log. So I would tend to I might give them one, and that's it, and then discharge, and then bye-bye. Give them a good send off. Here's the present, here's a steroid injection, see you again, and leave it to the GP or physiotherapist, because GP surgeries and also some physiotherapists can do them in the community. So we tend not to get involved in those osteoarthritis patients. But obviously, if they come to see me and then they're in pain, I don't mind giving them one or two, but I won't follow them up long term. Yeah, if it's osteoarthritis.
What about for rheumatoid arthritis?
Yeah, so if it's inflammatory arthritis, so the way we approach it is, it depends on the number of joints. So let's say, again, if you ask a different rheumatologist, they might be more, what's the word? Adventurous, I guess. So for me, if they have 3 joints or less, then yeah, I would inject all 3 of them. So let's say knee, elbow, PIP, for example. But then PIP is quite small. Let's say knee, elbow, shoulder. So 3, so that's fine. I can inject. But if it's like 2 shoulders, 2 knees, 2 elbows, 10 PIPs, 10 PIPs, I probably say let's give IM steroid, so intramuscular into the gluteal muscles, because that would give a more systemic effect rather than specific to the joints. So if it's 3 or more, then I would probably skip the joint injection and just give an IM steroid instead. Steroid, Dr. Hafiz.
Okay.
Yeah.
There's a question from Naeem.
Okay. So acutely admitted patients on DMARDs, what are the rules of thumbs in terms of meds that need to be continued, stopped, and the thoughts behind them? Okay, so DMARDs, so this is modifying anti-rheumatic drugs. They are immunosuppressions. So you need to stop them because they, as a general rule, obviously, because when someone has infection, and they're on antibiotics, you want to give them a good chance of recovering. So you want to stop the DMARDs when they're on antibiotics or when they have infection or when they have COVID-19 infection. The only DMARD that you probably would not stop is hydroxychloroquine, because it's, as I said, it's like very mild in terms of the immunosuppression. So anything else, I would actually stop. Some I argue that sulfasalazine doesn't need to be stopped, but this all varies between trust. But as a general rule, any DMARDs except hydroxychloroquine, we would stop it when they have infection. And yeah, that's what we would do.
And do you switch them to something else? Let's say if they are on, I'm not sure whether DMARDs in rheumatoid arthritis is considered as critical medicine. So let's say if someone come in with sepsis and you stop the DMARD, do you always have to switch to something else to provide cover?
Yeah. So yeah, very good question. So when they come in, let's say they have sepsis, yeah, so you won't give any alternative. The only thing that you give is just pain relief. So anything like paracetamol, NSAIDs, or codeine, or even morphine, if they can tolerate that, we would, we would just advise, yeah, whatever they can manage, because it's too risky to continue the DMARDs when they have sepsis or any kind of infection. So we just say stop it. And yeah, just pain relief. So they might get synovitis when they have sepsis, but that's the least of the concern, because sepsis is more, treat that first. And we would normally start DMARD back 2 weeks after the infection has resolved or the antibiotics have been finished, whichever is the latest. Okay, that's a general rule. Refer back to rheumatology? No, not necessarily. Because obviously, if we want to do that, obviously there'll be a backlog of patients that needs to be seen by rheumatologists. So they can just restart 2 weeks after the antibiotics have finished, without being seen by rheumatologists, unless of course there were other concerns. Other concerns meaning, let's say the bloods, they have pneumonia, LFT is deranged, and then 2 weeks after that, LFT is still deranged. So obviously you're not happy to start it, then you can refer to rheum. But otherwise, if the bloods are fine, no other concerns, just restart 2 weeks after that. So methotrexate, just start. Sulfasalazine, just start 2 weeks after that. Leflunomide, azathioprine, mycophenolate, anything really that they have.
Okay. What about if they suddenly become nil by mouth? For whatever reason, I'm not sure, but if they are on DMARDs, is there any option to switch that to intravenous option?
Interesting scenario. But yeah, I mean, if it's nil by mouth, let's say they're going to have surgery, I mean, there are ways to work around it, really, because methotrexate is just once a week, so we can just shift the days a bit. But the rest, sulfasalazine, leflunomide, yeah, I mean, they're more of a daily dose. So if they're nil by mouth and there are no options, so I mean, if they can have NG tube for whatever reason, that's fine if they can crush it. But if it's nil by mouth completely, then yeah, there's no really other option apart from, you know, wait until they're no longer nil by mouth. Some medications like methotrexate can be given subcutaneous. So if they come in that form, that's fine, because nil by mouth we would expect it just be temporary, unless because if it's like long term, if let's say someone's long term nil by mouth, maybe they have, I don't know why they would be nil by mouth long term, but if they are, then I guess we just have to think about subcutaneous options really for them. And if we still don't have any other options, then it just be IM steroid forever. IM steroid, that's what we can give.
Okay, thank you very much, Dr. Adlan. Any more questions from the audience?
No, I think they're tired already.
Okay, so if there's no more questions, then I would like to say thank you very much for joining us in the talk tonight. And hopefully we can have Dr. Adlan again in the future to give us a talk on GCA. So that will be a topic for another day, inshallah. But anyway, thanks very much. And please do fill in the feedback form for Adlan's teaching. And see you guys again in the future.
Great. Okay. Thank you for having me. Thank you, everyone. Assalamu alaikum.
Okay, wa alaikum salam.